We would welcome any questions and comments, not only directed towards our panelists here, but for those you wish to previous speaker as well. Yes, Alex.
Thank you. We are halfway through this very important meeting. It has been said already here that we are talking basically to convert. But there are masses of health professionals out there, not only in this country, and I'm speaking globally, that are absolutely unaware of elder abuse. And I remember that when I came to the States to live in New York, to work at New York Academy of Medicine, this is 2008, this institute, IOM, released a very important and influential report about medical education. We are failing our populations because basically we are not training. It's not only geriatricians. Quite frankly, I don't care if we are not training more geriatricians. What I care is that we are not training the health professions for the 21st century. Every single health professional should be much more aware of aging-related issues, including elder abuse. How many cases of elder abuse are misdiagnosed because you see that patient every week in your practice, depressed, and you fail to recognize that behind that depression, what you have is a case of elder abuse. And there is no possibility of a medical doctor, a nurse, or a home visitor to diagnose something that she or he is not aware. So I think that so far we haven't really brought the discussion into developing this awareness beyond those that are the specialists, those that will be doing the screening, but really to bring this issue to the core of not only medical education, but the training of the health professionals for the 21st century, or else we will continue to provide health professionals, like doctors, that know everything about child development and pregnant women. Women are becoming less pregnant, there will be less babies and children, and they will be dealing with elder abuse and other aging-related matters, ignorant. And this is iatrogenesis, including elder abuse misdiagnosis.
I like to bring up an issue that came up with Susan's talk before. I think in these interventions they were talking about, like with every intervention, we have to think about the potential adverse effects of these interventions when we assess the overall outcome. And I'm particularly concerned about the kind of boilerplate restriction on use of antipsychotics in the elderly. I think there are places in which they're useful, and the parallel example is the concern about antidepressants in youth and adolescence. And there was a black box, and because of the possibility that antidepressants would lead to suicide in adolescents, the federal FDA put a black box restriction on use or recommendation, be careful. So general physicians stopped prescribing antidepressants for severely depressed adolescents, and the rate of suicide rates in the young have gone up. And so these interventions have negative effects. I would think that one of the possible, I'm a little concerned about kind of putting a black mark on those institutions that have more than what percentage of residents who are on antipsychotics. And I'm not promoting antipsychotics, but I think there are negative possible outcomes. It might be that they would therefore be less likely to willing to accept people who are more disruptive, and they were leaving them the family. And you might also end up with more resident violence in those institutions, because you haven't limited that behavior. And so I think we have to, while we're assessing, have they come up to the standard of not having more than 15% of residents on antipsychotics, what has the result been in terms of the overall level of violence in those institutions? And just as sort of one marker of looking at the potential adverse effects of some of the interventions they were recommending.
I agree that we should use antipsychotics sometime, and sometimes that they're the right response and they help people. And within Britain, by the way, I'm not Irish, I'm Scottish. I come from London, but I sound Scottish because I am. And within Britain, we've got government targets and we have to see everyone every 3 months who's on antipsychotics with dementia. We have to have a written that we have reviewed them. But and our trust has the lowest amount in London of anyone in antipsychotics, but it's now getting to the stage where I've got families begging me not to stop them and saying, you know, we've tried this before, and they hallucinate and they get violent. And that's right. So there are times when people need them, and I completely agree with you. But there's no doubt that there used to be, and probably still is in a lot of places, a lot of people on antipsychotics in nursing homes that were not reviewed and were sedated, and it was harming them. So like everything, there are risks and balances, and I suppose pendulums swing a bit far sometimes, though I think as long as we are aware that we're trying to help people, be clear about it, that we should use them. But they're not terribly effective for just general agitation and difficulty. And I think we should be aware of that and be careful about them, but use them appropriately like every other tool.
Yes, Susan.
If I could just respond. It's obviously a very good point that there's two issues on the antipsychotic and then a third issue on a False Claims Act case and how antipsychotics fit in. So I guess first is the point that if there's an underlying mental health reason to be on an antipsychotic, certainly that antipsychotic should be prescribed. I think that the second point that CMS is making is that if an individual is transferred to a long-term care facility from a hospital or another long-term care facility, there should be an examination of both the dose and the number of antipsychotics to see if gradual dose reduction makes sense. And in terms of the third issue in bringing a False Claims Act case, you know, the overuse of antipsychotics is one component. You know, looking at a facility, if it is also having excessive pressure ulcers in low-risk residents, or a facility-acquired pressure ulcers and falls and overuse of antipsychotics, is at that point that you start to look and say that there's a problem. But I certainly agree with you that there can be unintended consequences. And I think looking at the issue of there must be a mental health basis for the antipsychotic and gradual dose reduction is a way to sort of, I think, soften the impact of what would otherwise be a fairly rigid rule.
Yes.
Hi, my name is Kimberly Scott. I'm a senior program officer here at the Board on Global Health at the Institute of Medicine. My question is for Dr. Dyer. In your presentation, one sort of just thinking and hearing about people not reinventing the wheel and sort of the use of DOTS and home visitation models to be able to have a successful intervention for vitamin D and adherence, and sort of looking at transferring that model into other medications and adherence. But I was curious about whether you all have costed your model. Home visitation, of course, always varies in terms of how much it costs, the cadre of worker, or what the workers are doing, issues of fidelity. So have you costed your model, and do you all plan to do any economic analyses, or have you done any for your model?
Thank you for the question. You know, it is quite costly to send out a nurse and a worker. We try to send people out in twos, so some of the situations are not as safe as others. And you know, do we really need an RN to do that? We did it because this was an intervention study in a vulnerable population, and working with the NIA and our IRB, that's what we felt was important. But we hope to, in the future, to study different models. For instance, if the nurse only went once a week, would that be good enough? Could we use phone calls? Could we use tearaway cards? And so we want to compare those things to find out what's the least expensive. So it's a very good point. Thank you for the question.
I sort of have a question for our panel. You know, when we think about social well-being, it's you know, to a social scientist is almost like saying what define aging. You know, it's social well-being. One may think of in many different facets. You know, social support is only one aspect of that. We can think of instrumental social support. We can think about, you know, perceived emotional social support. There are many different constructs within them. When we think about social network, You know, there's a social network density, there's social network quality. There's a way to measure them in a very different way. There's also social participation, social engagement. I want our speakers to, panelists to think, perhaps comment on, you know, when we talk about social support, I hear the term interchangeably about social network, participation, because some of the earlier evidence from Mark and others actually indicated that if you live by yourself, if you're social isolated, actually may be a protective factor against elderly because of you have nobody in your immediate environment, especially for for psychological and physical abuse, perhaps more so for financial exploitations from someone stranger, the nice young man who's calling on the phone says, could you donate $100 towards X, Y, and Z, or the scams that then be. So I want us to, if we go talk about this concept, I want us to have a better thought process along this pathway.
Shall I make a start? Yeah, you're absolutely right. I think perhaps there can be some overarching principles. So social support, it should be empowering. Another aspect, it should be what the recipient want, although it sounds so straightforward. But actually, when you put social support into an intervention, and that intervention, if you follow the protocol, the same should be given to everybody who receives it. Now, that can become a problem. Currently, we've got a huge cluster randomized controlled trial that's going on in Hong Kong, where it involves something like 350 couples in the prenatal period, follow all the way through to the postnatal period. It's low cost, and we also use our trained peers in the community. Now, what we found, which we did not realize before, and this is my point about really find out what these people need. Although it might sound so straightforward, but often one might not have done enough work on that. We thought we knew, but obviously we have not, because now, as we are using the intervention, we found actually our young couples, they are so well supported, sometimes by about 6 or 7 other adults in their home. They really do not want our peers or our researcher to go in and do any work. So social support in that respect actually is backfire on us. Whereas for another group, they're new immigrant from China, they love it because it's like a sponge. In fact, this woman actually said to me, I've never seen this in China, but I heard about it, I really want it. So now I'm in Hong Kong, and it's like a sponge. She said, it's like a sponge, I'm just soaking up everything. And for that group, we are seeing amazingly good results. So I think somewhere along the way, we need to have not only clearly defined components of what social support is, but actually putting it in context, or else you or I may come across the same surprise again. One is a negative one is a positive one. But either way, I think it actually would not help us to advance the science of intervention study.
I think if we adopt the concept of social inclusion, if we take that as our mantra and just use it as a basis, then it's going to cover, it's going to result in the type of social support that a person needs, because you're going to be including them, giving them the option. Do they want the support or not? But at least they have it. They have the option.
Yeah, I was thinking this as we talked, that everybody was meaning different things by social support. And I think it was initially mentioned that social support might be somebody coming in and doing activities of daily living support. And actually, I don't think that's what social support is at all. So I think we're all talking about different things. There was a randomized controlled trial done in the UK where they befriended families of people with dementia and sent in people carers to befriend them. And it didn't help because most people refused to, they didn't want them. They didn't regard them as their friends. And I sort of understand that. I'm pretty antisocial. Send me a random friend and I won't like them. and I think that's actually true of quite a lot of people. So you say, if you tell me that you're a health professional and you're here to do X, Y, or Z, I'll accept it. Tell me you're a friend. I'm going to be a bit more demanding about what I expect from you. And I think it's quite difficult to provide social support in that way, where you actually have some sort of intimate relationship or some friendship within that. So I think you have to, as you said, consider social inclusion, but you have to consider helping people ask for the help they want from their network, from people that they value, because I think often people don't ask. Maybe that's more true in Britain than in America, but in Britain people are often very, very reluctant to ask. And people might be willing to do things if they knew that that was what was wanted. So I think that can be very helpful. And just consideration of how you can have that friendship. It's not an easy thing to provide. And the fact that lack of it may lead to abuse doesn't necessarily mean that you can provide it. And then I want to move on to the fact that living by yourself is being protective. When I looked at the literature about who are most likely to be abusers, it seemed to me that it depended very much on the culture, and basically the person who looks after you is most likely to be the abuser. So if it's a culture when your daughter-in-law does it, she's most likely to abuse you. And if it's your husband, he's most likely. It's the person who has most contact. If you've got no contact, you're likely to be neglected, but you're not likely to be positively abused. And it reminded me a bit of an American cartoon, which I'm sure you have all seen, where they said that the children are most likely to be abused by their parents, and they send all the children into care. And I think we've got to get some perspective. Most people still don't abuse, and leaving people entirely isolated so that they're not abused is probably not the best thing in the long term.
Yes, Ron.
Yeah, make a quick comment on that. The number one risk factor for being abused is having somebody else live with you, but you need a perpetrator to have a victim in that case. The remedy wouldn't be to have everybody move apart. I think that was in a science fiction novel once, but the idea of Asimov, I think, so it's not simply living with somebody else that gives you social support. And you're right, it's different types of, Dr. Poniak is dead on, different types of support are going to be necessary and defined by the individual. We're at a very early stage in the research, and it's too soon to say what type of support, but in general, wearing a clinician's hat, I think community linkage is the type of support we're talking about, or access, not necessarily utilization, not necessarily acceptance, but access to and then utilization of both instrumental and empathetic types of support. This is what people are saying they need. Now, borrowing from my other hat as a clinician who treats veterans with post-traumatic stress disorder, again, social support, we say, well, they need social support. What we need is linkage. And then as a disaster epidemiologist, again, social support, it's that vague term, but what we're really talking about is community linkage and access to others when you need help. Access to others in terms of services, access to others in terms of specific help, access to others in terms of emotional help. But it's that type of access that's important. But it is, you're absolutely right, going to be context dependent, and it will have to be better defined than this esoteric social support, or else we run the risk of, you know, oh, well, they need quote-unquote medicine or psychotherapy. That doesn't mean anything. But we do know connection to the community is important. But I'd like to highlight that we have absolutely no shot at getting there, meaning getting to where we need to intervene, if we consider what Sid said. And Sid, was it 11 million for all federal agencies? Okay, so there's no shot. I mean, there's no reason to even talk about this. 11 million for all federal agencies. I would like to know how much is spent across federal agencies on ink pens, because I guarantee it's more than $11 million. So across the country. So if $11 million is how much is spent, and that's after the NIA calling meetings of experts, CDC developing elder maltreatment, a third word, maltreatment definitions, in the last 4 years, if all of this attention is on here, congressional testimony, and it's $11 million after all of that publicity, and a lot of it's going to go to financial exploitation, meaning one subtype from NIA, the one we hope would be the big hitter, This is disconcerting and very depressing. So I think that the most important thing I've heard today is the $11 million figure that Sid pulled out.
May I comment on that? You know, what I would say about that is speak to your congresspeople. You know, write letters. We can't slow down. We've got to aggressively and progressively make our points and move it ahead and partner with the groups that can help us.
Yes, MT.
Marie Trace Conley from the Wilson Center, and I echo what Ron said, and we'll be addressing it more specifically tomorrow. But specifically to your point about the cost effectiveness about house calls, the VA has a small study that shows that they're actually very effective controlling for a number of factors, or cost effective. And there's a very interesting program here at the Washington Hospital Center, large house call program that services a lot of the poorest areas of the city. And I would love to see them do some sort of a cost study as well.
Shane, can
Yes,
I
Kathy.
add one thing in relation to what you were saying about social support? I think there's basically three areas that we have to consider with respect to how social support might be influential. I think we're all probably on the same page in that the presence is something that, you know, we see as being key. But beyond that, and I think this reinforces some of the conversation that happened earlier, we have to think about things like the character and the quality of the support. Because I know this isn't really talked about that much, but you can have a conception of support as something that's universally positive, but we know it doesn't work that way in every situation. And you can have unwanted support that actually proves to be harmful to an individual in the situation. I think as we referred to a few moments ago, the matching part of this is something we also mentioned. But I think one thing we would be remiss to also leave out is that we have to think about relationship history and whether or not the dynamics of the relationship has introduced an element of nullification where someone who's been a constant source has been drawn on to the point where their support, even in a group context, doesn't work anymore. A second area that we have to think about in addition to that is we got to get a good understanding of which particular emphasis point we want to focus on. There's a part of this that's individual level, as in subjective and how that affects the individual situation. But we also have to think about whether we can pull this into a situation where we talk about social support and how its impacts are objectively measured. And the last little piece of this is the construct level is something we got to clarify. We keep talking about the relational piece as if we're talking about one-to-one relationships or small group relationships, but this idea of community and social capital is also something that we have to draw on if we're going to look at policy level interventions to deal with systemic initiatives. So,
I very much echo. You know, in Chinese culture, when we say social support, we use a term called 谈心. What that translating is to talk heart, is to someone that you can pour your heart out to. That's what it means in our culture. Imagine finding someone to be able to do that for any of us. You know, I think especially someone who's being victimized in that culture context. So, Assistant Secretary.
Well, there is a large pile of money we should consider looking at, and that's Medicaid. And I wanted to talk about that briefly. With new opportunities because of the Affordable Care Act, I mean, we have states who are increasing their emphasis on funding home and community-based services, which of course has been around for decades now, but new financial incentives, new movements towards rebalancing. And one of the biggest challenges that has been there that's even become more clear is the lack of quality measures on how you measure home and community-based services. This is largely framed around Medicaid because that's where the big money is. But in conversations that I have, and these conversations happen at CMS, they happen various places within HHS, how do you measure quality services in the community? Because we're best in this country at measuring quality measures in a medical setting or in an institutional setting. And the goal for people who've been spending decades developing community-based services is not to medicalize them, but to measure quality of care. I mean, we don't want care to devolve, but quality of life. And the quality of life thing still feels a bit amorphous to us. But the research that you all have done and are doing on showing that social inclusion can decrease the risk of elder abuse is actually a very germane conversation now in the Medicaid world as we talk about quality measures. So I would kind of add that pile of money. The little sad 11 million is too true. But the Medicaid resources right now, This is the time to be having these conversations with CMS, with us, with state Medicaid directors, with researchers and funders, because there are foundations in the grant makers in health, grant makers in aging, who say, how do we know how to measure this? You actually have something to bring to the table to say, measure this and implement these instruments, and you can move this issue by way of Medicaid. And it should be one of many measures, but as a solid one, I think that there's enough to work with based on what you all have been talking about today.
I very much echo that. CMS will be here tomorrow talking about some of their initiatives we've been working on. But also, when someone becomes financially exploited, many of them are, transitioning to the Medicaid program. So their resources being taken, their houses being taken, they're signing documents they may or may not be aware of the consequences. And I think that's perhaps a fruitful opportunity that we should embark upon. Thank you. Other questions, thoughts, and comments to any of our speakers throughout the day? If not, can you pull up the last? I think it's, you've heard lots of discussion today about people's perspectives and thoughts, and I think certainly take with what you feel as that are important to you. This is a slide of actual $100,000 U.S. bill. This is MT should know this is Woodrow Wilson, and on the bottom is a 1792 silver Liberty Lady penny that was just recently auctioned about a year ago in Chicago for $1 million itself. So as you hear our experts and leaders talking about our conversation today, keep in mind of what may be the most relevant to you. And at the same time, I think the point of collaboration, you hear, certainly our field has, you can understand the complexities of our field and where that often can be an impediment that often mobilizes it in terms of moving forward. But I hope you also appreciate the successes that have come from those collaborations. This is a picture of known as the Thor's Well, is known as the Cape of Perpetua in Oregon. And when the water is just right, it's absolutely it's an amazing picture. And I think highlight the potential successes in interdisciplinary or transdisciplinary collaborations that we can make in terms of moving the field forward itself. And I think as we move forward into the discussion tomorrow, continue those type of discussions and thoughts and questions in terms of pushing us forward. Those issues certainly not easy, but if we're not ourselves critiques, rather than it's better to be our own critique and have somebody else who really doesn't understand our field as well. And I think asking those type of questions will put us in the right framework into thinking about those things. And as we part the day, we hope you had fun today and enjoy your evening, and we look forward to seeing you tomorrow. Thank you.